to this debriefing session and good evening to our faculty, Dr. Parthajit Das. Our faculty for today, Dr. Parthajit Das. He is the consultant rheumatologist in Apollo Multispeciality Hospital, Kolkata. And he has previously worked as a consultant rheumatologist at King's College Hospital, London and Kettering General Hospital in UK. He has published in several peer-reviewed and international journals. He has co-authored several chapters in various national and international monographs. He has been nominated as the teaching lead for the medical students at the University of Leicester and was awarded honorary lecturer in 2016. He was awarded FRCP Edinburgh in 2017 and FRCP London in 2018. He has enjoyed his role as an MRCP examiner, and he is a member of World Health Organization Rehabilitation Peer Review Group. Thank you.
Yes, so I think let's start off. So first question, is a 57-year-old gentleman, known diabetic, seen an annual review in a diabetes clinic. Glycemic control is suboptimal on diet alone, and the most recent HbA1c is 63. It was elected to be treated with metformin 500 twice daily. According to NICE guidelines, management of diabetes, which of the following is most appropriate interval to recheck HbA1c? So what's the answer? So it's basically 3 to 6 months, because the lifespan of RBC red cells is 90 to 120 days. And is always recommended to check HbA1c. It's difficult to check every 3 months, but at least 3 to 6 months should be fine, just to have an optimal glycemic control. So next question, this is again a very straightforward one. So 48-year-old lady attends diabetic clinic for annual review. BMI has increased over the year to 34.3. How is the BMI calculated? So again, this is quite straightforward. Anyone can answer? You can type in the box as well. Yeah, I think that's right. So yeah, I think Sneha is right, Ronojoy is right. So this is weight per high square. This is very standard therapy, but you need to know the figures. So if it's underweight, means less than 18.5. Normal is up to 24.9. So 25 to 29.9 is overweight. And anything more than 30 is obesity. And if it's more than 35 is a morbid obesity, really. So this figures or this numbers might have some bearing in the future. Sorry? No, I mean, in that case, the next question is a young lady, 26-year-old, presents to obstetrician with 25 weeks pregnancy, with profound tiredness and anxiety. Examination reveals tremor, pulse rate tachycardic, 105, soft bruit over the thyroid gland. The thyroid function shows FT3 30.8, which is high. TSH 0.5, which is lowish, quite low. So which of the following assessments should be selected for this lady? So what should be the basically treatment options? Is it potassium perchlorate, radioactive iodine therapy, propylthiouracil, propranolol, or carbimazole? I think I'm sure he had these questions for the mock test, isn't it? C is Nuida has mentioned C. Ronojoy has said E. I think Ronojoy is right this time. I think Nui's probably the concept is okay, but you have to clarify a few things. So this is a Graves' disease. From the history is a pregnancy, the thyroid bruit is there. The thing is, carbimazole is associated with increased risk of congenital malformations within, what do you call it? Just a second, let me check this out. Is this blocking the screen? No, I think so. So carbimazole is contraindicated only within first trimester. And thereafter, I think for the adequate control, that is the drug of choice, even during pregnancy. But if the question would have been mentioned first trimester, then propylthiouracil would have been the better option. But other options, like Radioactive iodine is contraindicated. Propranolol is just a symptomatic relief. It's not treating the condition. And potassium perchlorate is not the treatment of choice, especially in this situation. So the question is, answer is E, which is carbimazole. So next question is, right, so next question is, a 32-year-old lady presents to a GP practitioner with complaints of tiredness, anxiety. So I think there would be, yeah, in the 3rd trimester for second pregnancy. Examination is unremarkable, blood pressure normal, pulse normal, BMI is 24. Our abdomen is consistent with 31 weeks pregnancy. The GP practitioner decides to check thyroid functions. So which of the following is considered normal? Following is, I think this is quite straightforward, really. I think you probably will all get it right. So it's infectious mononucleosis. This is very, very common in UK, and the drug of choice is ampicillin or penicillin, really. So everyone got it right. She's a 40-year-old lady with acute chest pain and dyspnea. Examination reveals bilateral ankle edema with 24 hours protein 6 grams. So which of the most appropriate explanation of this? So what is going on? So it's a 40-year-old lady, acute chest pain, shortness of breath, bilateral edema, and nephrotic range proteinuria. So what is the diagnosis here? So if you know the diagnosis, you'll get this right. So which of the most appropriate explanation? Reduced factor 8, reduced concentration of 1 milligram factor, reduced fibrinogen, reduced antithrombin 3, factor laden. Which is right here? I think what happens in nephrotic syndrome, which anticoagulant protein you lose? This is not factor laden, this is antithrombin 3, because if you have nephrotic syndrome, you lose quite a bit of proteins, and that drains the antithrombin 3 levels, and that causes a risk of thromboembolism. So I think we are done. We have done more than 50 questions today. But any questions for me? I think probably you can just a sec. You can stop share. You can feel free to ask questions if you want to.
Participants, if you have any queries for Dr. Das, please feel free to ask.
Hi, Doctor. Good evening.
Hi, good evening.
Yeah, it's regarding the RTSE with the left homonymous hemianopia. It was not clear.
Right.
The neuro question, I don't know which question number it was. If you could explain a little, because you did explain, but it wasn't very clear.
No, I think question which was, because if it's one part of the brain is involved, one side, if it's a cortical manifestations, cortical stroke, then is everything will be happening in the other side.
Of course, it's crossed, fibers are crossed. Yeah.
So this patient, if I'm not wrong, had a left-sided facial weakness, left-sided hemiparesis. So if the hemianopia happens, it has to be on the left side. It can't be on the right side. So this is the simple clue to answer those questions. And if you say total occlusion, that means that will include the facial nerve and the all the tract and the homonymous optic tract as well. And that all be in the one side. So that's the only clue. Is it making sense?
Yeah, it's not very clear though, to be honest. So anyway, yeah, like I got a clue. I had to read on it. Yeah.
Because the other answer was right-sided homonymous hemianopia. That's not a possible. If we have one-sided hemiparesis and the other-sided cranial nerve dysfunction, like either facial nerve weakness, that's a crossed hemiplegia. So cross hemiplegia happens when there's a lesion in the midbrain.
Right.
But this is a cortical. So that's much higher level. So in one side, you have the lesion, all the presentation will be on the right side. If you have a right-sided MCA territory stroke, which is a CASI, then all things on the left side manifestation, left hemiparesis, left-sided facial palsy, all those things. Is this making sense?
Yeah,
Because that is all upper motor neuron.
Yeah, UMN. Yeah.
But if it's a cross, then is a upper motor for the stroke and
Right.
the lower midterm cranial nerves involved of the facial nerve or whichever cranial nerve. So the label comes to the midbrain, where the facial nerve nuclei or the cranial nerve nuclei are present.
Yes.
Is it making sense now?
Yeah, yeah, doctor. It's better now. Yes.
Thank you.
Thank you.
Anything else? Any other things we need to be discussed? But having said that, I mean, if you read through the questions and if you practice the questions regularly, it will be very, very easy to pass. Trust me. And how did, let me ask you anyway. So how do you think this course is helping you? Or anything you want us to improve? Just feel free to ask. I mean, tell us now, because I think our IT team is also around. So we can always help you in different ways.
One suggestion, doctor, I don't know whether admin also is listening.
Yeah.
What I felt, we discussed the questions and the 2 hours.
Yes,
are
Dr.
gone.
Dharam.
Yeah, can you hear me, sir?
Yeah.
Yeah.
Sure.
So, like, since I look at your background, you are a trained rheumatologist. So,
Yeah.
MRCP specific rheumatology, tips could be discussed just before we start the questions, because these questions are and MCQs after all, and we are anyway doing it past test and others. But to have a core concept of rheumatology per se, like how you put up the Euler, definition of the points more than 6 or less than 6, or like the curve 65. I mean, these are basic oft-repeated questions. So specialty based, if these snippet points are being presented in the class, I think it will be more helpful, because either way, I'm sure all of us are doing MCQs. Just a suggestion.
We'll try that. We'll also let our faculty members know. But having said that, I mean, those things, do you want us to include this in the presentation as well, is it?
Yeah, say, like, since this is a mixed one, mega test, I expect. But say if you take a rheumatology per se, or like a dermatology example, so erythema nodosum is specific. So we know that these are the manifestation in these different diseases. Already we have a mapping in the brain that, okay, we need to correlate them. So that way, specialty specific, especially subspecialty, it would be really helpful if we can come down to criteria like the LTOT, nice criteria, like BTS criteria. We know that we need to read up, but if it's taught over the interactive sessions, we tend to remember more.
We'll probably try to do as much as possible, but I think most of this has been discussed in the video tutorials. If you run in the tutorials, most of them are discussed there. In terms of guidelines, what you have to read, and most of our video has been done by the UK consultants, because they're most of our friends, they're all still working as consultants. They're all trainers in MRCPs. Few of our consultant friends, like I won't take the names now. That of Robin Ray, is a consulting cardinal St. George's. He used to run the London Pacers course, which is one of the most popular courses in the world. Really. He has just stopped it now and he has joined us.
That's great.
So basically, they have delivered a very good quality videos. So if you have any questions, just go back to the tutorials, because we have aimed to do the tutorials. I think every subject has, say, 8 or 9 tutorials, probably more in few of them. That will be a refresher. So if you have spare time, just have a read through it, and not read, just see the videos, and that will give you a refresher things. And then you start solving questions. I'm sure you're doing questions from other courses as well.
That's right.
That's right. So, but you don't have much time to read. That's the problem. When I did my course, because I was really working, I was doing nights, I was doing daytimes. I hardly found time to read. But this sort of course, if someone would have taught me just listening to the videos and just flushing or kind of reading, seeing the slides, that will make a massive impact really. So once you're stuck with something, if you go back to the tutorials and read the specific, let's say rheumatology, there's a rheumatoid specific, SLE specific tutorials, just have a read through it. And they have everything in details there.
Sure, Doc. Thank you. Thank you.
Okay, and that's the whole intention of this course, so that we can surpass the books and save your time. And again, yet all these videos are very high quality. And they have been made by very experienced tutors. And they're all still practicing as consultants, mostly in UK. Okay, is it making sense? Right, any other questions from anyone? Right, admin.
Well, if nobody has any questions, then we will wrap up this session.
Okay.
I don't think we have any, to be honest.
Hello,
And
sir.
oh, okay. I think Dr. Singhi
Sir.
might have.
Yeah, tell me, how can I help?
Hello, sir. Can you hear me?
Dr.
Yeah,
Singhi,
I can hear you.
Hello,
just-
excuse me. There was
yeah,
a
just-
slide in a infected.
Sorry,
I think she might be facing some internet issues.
no, just or you can type if you can't. I think we can't hear you. Your voice is getting broken down. Either you can tell me pathophysiology. Pathophysiology is difficult to explain now. But having said that question, if you look at the options, let me find where is it. It would be difficult because sometimes even if it's you have to go for other options, whether those options are explaining the question. Yeah, here we are. See, I mean, I think you're asking for this question, isn't it? So this is a middle-aged lady, known HIV infection, and all the symptoms has been there for last 1 year. So if you exclude, just forget about HIV dementia. If you think of other options, whether schizophrenia will present in this way, like poor execution, might do, but over 1 year, which is gradually progressive, and there are signs of hallucinations. So hallucination is HIV dementia, one of the core criteria, one of the core findings. But cryptococcal meningitis is a very aggressive acute symptoms. Over 1 year, you can't explain the symptoms with. Again, same as toxoplasmosis. So all these features, toxoplasmosis either is a single ring enhancement, multiple rings. It depends which part of the brain is involved. But this constellation of symptoms which has been mentioned is gradually progressing, is explaining a syndrome. So syndrome here is PML, but PML is very aggressive disease and patient mostly die of it if it's not treated properly. But 1 year of PML symptoms without treatment is very, very unlikely. Again, for schizophrenia, all these things are not matching up. Like they're more psychotic. There's various types of schizophrenia, probably you're right. But this pattern is more matching up with HIV dementia.
I think Dr. Singhi replied in the chat.
Okay, yeah. Because the thing is, sometimes it's very difficult because there's very close approximation in the answer section. It's difficult to choose. But in that case, you have to choose from the time scale. Because other A, B, C, D, these options are difficult to explain over 1 year. Schizophrenia is probably, it's explained many of it, but the slurring of speech. Because slurring of speech is not properly schizophrenia. That's more of a psychosis, paranoia, and all those things. Self-harm, psychosis is there already. So everything is matching up with dementia, but not with others. So it's a kind of a diagnosis of exclusion. Okay. So if you guys are happy, we'll probably wind it up. We'll call it a day.
Yes. So thank you for this session, Dr. Das, and thank you to all our participants who actively participated.
Okay. Yeah, that's fine. Thanks for your help. Thank you.